Today, I want to, before I turn it over to Markway, who's going to start us off today, I want to introduce you all to Jessica Keene, who works with me here in Florida. I am really enjoying being on all of these meetings with you, but it means I'm not getting my other work done. So, in order to catch up with the rest of my work, I've asked Jessica to start. Initially, she's going to just join us, and right now she's doing all of the things that I normally do when I'm not talking. But starting sometime next week, she will be me in these meetings, so she'll be doing all the background, making sure things are happening, making sure you get into the meeting and that the sound is controlled and all of those bits and pieces that have to happen to make things work right. So I want you to see her and know that that's who she is, and that probably Wednesday, sometime next week, she'll be here and I won't. So anyway, I wanted you to welcome her. Markway, I'm just going to turn it right over to you so we can get started.
Thank you, Kim. Good evening, everybody. I hope we are rested, most of us, because it is Saturday, and hopefully you are not at work. So yesterday we started the discussion with Moses on components of continuum of care. And I'm putting on my slide here. And he did take us through to, okay, let me just see what is it here. He took us through to screening, and he defined what screening is. He also made a clear distinction between what screening is and an assessment. So I'm hoping that we still remember what the definition of screening is before we delve into assessment. The definition of screening, as it was discussed yesterday, was that the purpose of it is to determine whether there's a presence of a problem and the level of intervention that is needed out of having those results. Whereas assessment actually seeks to determine the nature of the problem and the follow-up or the level of interventions that are needed. And therefore, for assessment to happen, it's for individuals whose screening results indicate that they have a severe risk of SUD or are actively using psychoactive substances, and therefore they need to go for assessment and treatment planning. Now the question is, what are the goals of assessment? Assessment provides us with a foundation for treatment planning. The information that we get through our assessment actually is the one that determines the type of treatment that our clients actually would require, the type of treatment and the duration of treatment that they are going to require. It establishes a baseline for measuring clients' progress. So when our clients come, they are at a certain level, and therefore when you do assessment, the information that you gather actually would be a basis of where you start. And therefore it helps in terms of actually going back to see whether there has been progress or not. Assessment also helps us to prioritize a client's problems. With assessment, as you will see in the next slides, it actually helps us to gather information holistically, not only just SUD, as we have actually discussed the past 2 days about the fact that our clients have different assets in different domains. So assessment helps us to identify either family issues, work issues, whether there are problems, whether there are legal problems. And in gathering that, then it helps us when we do assessment to actually prioritize and see what is supposed to be actually attended first as per the problems that are being presented. It set priorities for treatment, I've already mentioned that, and case management intervention. It also helps us to identify the client's strengths and other recovery capital that can support recovery. When we do assessment, we actually look at different domains, and therefore we are able to actually identify recovery capital that can actually support the recovery. Now, assessment starts with engaging the client. The first step of engaging the client is actually very important and very crucial. Engagement is important because it sets off the tone in terms of how you are going to actually work with the client. Therefore, we need to pay attention to the environment and the climate in which we provide assessment. The first thing that we also need to be cognizant of is to acclimatize the client and maybe orient them in terms of what we are doing, so that we build rapport with the client. Building rapport with the client helps them to actually have a sense of trust, so that they are forthcoming with information that you are going to be asking them. The second task is obtaining the client's history. There are different ways in which you can actually obtain the client's history. You can do clinical interviews. We have structured interviews. Some interviews I've seen in other facilities that are not so structured, but at the end of the day is to get the client's history, which is very broad, as we will be discussing later. You could also review the client's existing files or information if you have to actually get the history. The third task is collecting data on the client. The same thing, you could review files that are existing. You could also get collateral information, of course, with the permission of the client, to actually augment the clinical interview. Very important while you are doing that is to observe the client during the first visit. Why? You would want to observe verbal, pay attention to the verbal, and also pay attention to the non-verbal cues. This information would help you when actually determining the mental status exam, because you would want to observe the mood, the affect, and just pay attention to whether their face and what they're saying are congruent. Very important in actually thinking about MSE or the mental status exam. So the first part in terms of areas of assessment, because I've already noted that the information that we gather about a client is not just for the use of substance, but very broad. You would want to know the reason for them seeking treatment and their opinion of the problem. This relates more to you being able to determine the level of motivation and the level of motivation in terms of engaging in treatment. It also helps you to actually see where they are in terms of the stages of motivation that Beatrice talked about yesterday. Whether it is somebody else saying come for treatment or they actually see it as a problem. The information about the client's opinion about the problem also gives you information regarding the insight and judgment about the problem. We also want to look at the current and past substance use and drug treatment. That information would help you in terms of determining the patterns of drug use. It will also help you to determine the recovery, if there was any recovery, whether there has been any lapse or relapse. And you would also want to get information in terms of when they first started using the substances, the types of substances they're using. Additionally, family history of substance use is important in terms of gathering information, as this part also can actually help us in seeing whether the family is an asset or a recovery capital or not, or some of the things that actually could contribute into being a barrier. We also gather information on medical conditions and complications, because we do understand that sometimes our clients have comorbid or co-occurring disorders. And therefore, when there is co-occurring disorders, it does make treatment more challenging as compared to when you just have one single diagnosis. The other area of assessment that we need to pay attention to is the risk of withdrawal and the need for supervised detox. We know that with withdrawal, there is physical risks that are involved when it comes to withdrawal. So in gathering information during assessment, you would want to pay attention to whether the client has risk of withdrawal, so that if there is need, they go for detox that is supervised. We also want to assess and get information regarding suicide. Suicide ideation, do they have ideas about suicide? Is it current, past ideation? Have they ever attempted suicide? And if they have, what kind of methods did they use? Because literature does show that there is a link between substance use and suicide. And sometimes using psychoactive substances actually increases the likelihood of somebody having suicide ideation, let alone attempt. You also want to assess other crises in the client's life. We also gather information regarding emotional, behavioral, and cognitive status, including the presence of a mental disorder. The emotional, behavioral, cognitive status also helps us in terms of engaging the client. At what level are we able to communicate with a client? Somebody who is a teenager as compared to somebody who is a 50-year-old, there's definitely different cognitive developmental levels, and therefore, when we do have that kind of information, it does help for us to engage at the level at which they are at. Information regarding educational and vocational background is very necessary, because for this type of information, it helps us determine the type of recovery capital that one has. Somebody who does not have any vocation or have or the educational background is low, you probably at some point would want to engage or maybe link them with services so that they attend to those. Continuing with areas of assessment, we also assess the legal status. I know in my clinic, usually when I ask this, people get surprised. But when you think about the field of addiction, some of our clients are in correctional facilities or have criminal background or legal background, and therefore it will be good to get that information. If there is a legal status, we can refer them to for legal assistance and all that. We also assess readiness to change. As it was said yesterday, remembering that stages of change, just so that we can actually properly plan to intervene at the stage of change that the client is at. Continuing, we assess and get information about family, about the workplace and community, whether these domains actually add to the recovery capital or they are a barrier. And then when we do treatment planning, we use them. If they are an asset, we use them as part of the strengths that somebody actually has. We pay attention to relapse and continued use potential. We want to understand the history of relapse, what contributed to relapse, so that we can build relapse prevention skills. And then when there is continued potential, we also would want to give psychoeducation, which I know my colleagues will probably go into details with. We assess recovery environment, the living situation, who do they live with, the neighborhoods, are they barriers, are they neighborhoods that when they leave your facility, do they have support systems in those neighborhoods? Now, coming to how do we gather all this information that seems to be very extensive? What are the methods that we utilize to get the information? I've already noted earlier on that a clinical interview is one. Some facilities have different clinical interviews, but what you would want to capture when using a clinical interview is obviously what I've just discussed with you. It's holistic information about the client. You could also use assessment instruments, and I wanted to just ask our participants or colleagues, what kind of assessment instruments do they use in their facilities? And I'm gonna just ask you to just note it on the chat room, and then kindly, Kim, you could just read for me that. What clinical assessments do we use in our facilities?
The Addiction Severity Index.
Yes, actually, that's the one that I was thinking of Addiction Severity Index. It seems as most of us use that. Is there any other assessment instrument? Think about it, like, you know, sometimes when we think about assessment and screening, I know sometimes we forget the difference. Assessment actually goes deeper into determining the nature and severity of the problem. So Addiction Severity Index is one. Any other?
SCID 1 and 2. I don't know this one. SCID.
SCID.
Yeah, I don't know.
What is, can you tell us what that is?
Rania, can you unmute yourself?
I mean SCID 1 and SCID 2 for detection of the axis 1, axis 2 psychiatric disease comorbid with addiction, according to the DSM-5.
Oh, okay, that's a clinical. Okay, yes, that's another assessment.
SCID 1 and SCID 2.
SCID 1 and SCID 2
for all psychiatric disorders, and SCID 2 for personality disorders.
Oh, okay.
Psychiatric, yeah, but with addiction.
Yes. No, thank you. Any other assessment instrument specific to issues of addiction? I know in module 5 we'll go into details about the different assessment instruments, so it's okay. Thank you for those that noted the instruments in the facilities. We also gather information using collateral sources, and most important to note is that you have to get the client's permission when you do that. When you call our family members, when you call friends and employer and referral sources, and we have to be mindful of who we call, because I know sometimes when we call an employer, they would say more things and all that. So we have to make sure that it's of clinical relevance when we do get this information. You can also get assessment or information that you need about drug use by just using urine or other testing methods for substances. After we get the information from assessment, which actually informs our treatment plan, we go into the next phase. As said in the slide, we do treatment planning. It's very important to get thorough, detailed information so that it can help you to plan accordingly, individualize it to the specific needs for your client. So treatment plans should be specific, should be individualized so that they meet the client's specific needs. I know in some facilities, sometimes we have a generic treatment plan, but it doesn't always necessarily meet the needs of our clients. That's why it's important to do a very thorough and extensive information gathering about our client. So to note, it's individualized, right, outline, and it has to meet the client's specific needs. A treatment plan that is effective, that is individualized, will be addressed, needs to address the following, or identifies needs that will be addressed during treatment. It identifies needs that will be addressed during treatment, sorry about that, what will be required for referral to other treatment providers will be deferred at any, or to a later time. So when you have a treatment plan, It should identify needs that are immediate or that would be dealt with at a later time. It also identifies whether there would be needs that can be provided by your own facility or that you need to refer to other treatment facilities. Because we do recognize that facilities are different in terms of the services that they provide. Some facilities probably would attend only to SUD, whereas there are facilities that are in a position to attend to both co-occurring disorders if people have other mental disorders. So a treatment plan needs to identify those. An effective treatment plan should be individualized, as already said. It should be flexible. It should be flexible given that our clients' needs actually change with time. It should be realistic with behavioral objectives that are measurable, that are achievable, and those objectives should be also observable. So when we do our treatment plan, it's always encouraged to maybe think about objectives that are SMART so that you are able to assess the progress more effectively. The plan has to be simple. Simple in the sense that our clients are able to understand what it is that we have recommended, obviously cogently with them. It also has to be simple so that family members, if they are involved, they should be able to understand. We know that treatment planning also involves other service provider or staff members. They should also be able to be conversant and understand what it is that we are trying to achieve with our clients. It should be useful. The plan should be useful with measurable indicators. So it's something that should actually help us to achieve what we've set ourselves for. It should focus on solutions and strengths rather than on the negatives. This is very important. We've talked about the fact that for recovery capital, we focus more on the strengths than the negatives. So we want to make sure that in our treatment plan, we look at things that have results. It should be clear in identifying the type of treatment, the frequency of the treatment that we want to offer our client. The plan should also be responsive to changes and progress. As I've already said, obviously when people come in, they are at a certain level or a baseline, and therefore the treatment plan should also be responsive to the progress that one actually achieves. Now, treatment planning should also determine the level of care that the client needs. And important is that the client should be willing to accept the intensity of the care that is being given, the duration of the treatment, and the setting in which you are actually offering treatment. So it's important when, let's say maybe you are in a facility and you want to refer a client, they should be willing to go to that facility. They should be willing to actually go to a different facility and also understand the very three criteria in terms of intensity and duration, because sometimes we refer our clients and we do not take cognizance of the fact that they have to be willing to actually participate in those treatments. The first step of treatment planning includes determining whether, right, the program can meet the client's need or should be referred, right? The treatment for co-occurring mental or medical, whether the co-occurring mental medical disorders is needed. The client is in need of supervised detoxification. When we do that, when we do treatment planning, we should be cognizant of the fact that, you know, treatment facilities are different. I know sometimes facilities keep people, but when you have a facility next to you that can actually meet most of the needs, it's actually more advisable to actually just refer your client or your patient to those facilities. So I know I have about 2-3 minutes that I'm going to use to just ask our participants in terms of the types of treatment plans that they actually utilize in their facilities. As the things that we've discussed in the slides or here are the things that you do in your facilities, what is different, what is similar. Just 1 or 2 people.
But while we're waiting for somebody to type a response or raise their hand, you did have a question about, do we have templates that we can share that would be sort of a standardized template that people could use that incorporate all these elements?
Yes, in the manual that you are going to receive, the trainer manual actually has different templates actually that you can use that can guide your own template. I don't know whether in the participant manual, but I'm sure that in the trainer manual we do have them in the resource page, and it actually has links as to where you can get some other treatment plan templates. Even for assessment is there in the trainer manual. So clearly you would have that. It has consent, like remember the slide where we talked about getting collateral information. It has a template about consenting to get information from other people. Any person who wants to share before Moses comes in? Is there anybody who has written?
Let's see. I'm working in a 1-month hospital-based program, 4 months and 9 months residential program. I don't know if she's typing more.
Mm-hmm.
Oh, and we have a question about general medical complications, like the thought that should be included in a treatment plan. Those comments, I'm not sure I think it's more discussion, not directed toward.
No, with that, let me allow Moses to start his presentation. Thank you. Stop share. Thank you. Moses, you can take over.
Yeah, well, good evening to you all and welcome again to another presentation. I'm going to be talking, about detoxification today, and then case management. So let me share my screen. So can you see my screen now?
Yes, it worked.
Okay. Yes. Thank you. Unfortunately, my own system doesn't allow me to show the video and then the slideshow at the same time. So once the slideshow comes up, then it cuts off my video. So we will continue with detoxification as part of the pretreatment program or pretreatment components. So what is detoxification? We're not going to go in depth into what detox is all about and maybe the kind of medicines and protocols we use for detoxification, but we just have an idea about what it is and then just the concept and how it is done. The process of stopping substance use and then clearing the substance from the body and managing the withdrawal syndrome. That's what detox is all about. I would like the participants to tell me what they understand by the term withdrawal syndrome. What do you understand by withdrawal syndrome? Please, anyone can share. You can type it on your chat box and then Kim will help me read the answers out. What do you understand by withdrawal syndrome?
Nothing yet. It takes a minute.
Okay, yeah. But it's not just stopping substance use, but also making sure that the substance is cleared from the body. And then we were able to manage also the withdrawal syndrome, because that can be a big problem for some who really want to access treatment. They are scared of the withdrawal syndrome. So what is withdrawal syndrome?
So you have a couple answers now.
Please.
The symptoms you experience as a result of stopping a substance.
Okay.
Physical or psychological symptoms as a result of reduction or cessation of substance use. Now they're coming in fast and furious. They are the symptoms one manifests after stopping substances, when a patient experiences psychological, physiological and psychological symptoms when a substance is stopped. So pretty much a lot of answers basically saying that same thing.
Okay, thank you very much for your response. It's very good. But you know that withdrawal syndrome, are specific, for substance, for the substance. So withdrawal symptoms for alcohol might be different from the one for opioids, and also different for the one who are maybe on benzodiazepines and other substances. So they are specific and they are predictable. Thank you very much. Let's go on. Withdrawal. The particular signs and symptoms, the intensity of them, and the risk involved in withdrawal depends on the substance used. Then the amount taken over time, and the length of time the substance was used regularly. When we talk about withdrawal symptoms, it's only those who are addicted or dependent on substances that develop withdrawal syndrome. If someone is just starting maybe substance use and is abusing it, is not developed tolerance yet, and not taking it for a long time, you don't usually experience withdrawal symptoms or syndrome from such people. But when dependence sets in, or they are addicted to the substances, that's when you begin to find withdrawal syndrome. And so the substance, the amount, and then the length of time the substance was used regularly, are key to the withdrawal syndrome, the intensity, and the risk of developing withdrawal syndrome. There are all kinds of medications that help with detox. There are medications that help with opioid detoxification, and then some for benzodiazepines, and then barbiturates, and other sedatives. But as it is now, the literature is not actually conclusive for medication for stimulants like cocaine and amphetamines. So you find that most of the withdrawal management for stimulants and amphetamine, is supportive care, and people are, free, or clinicians have a lot of latitude to use all kinds of substances to manage the withdrawal from stimulants. And most times you go with the symptom, is more or less symptomatic. And a lot of them will also benefit from antidepressants, especially when they're withdrawing, because the withdrawal symptoms are usually the opposite of what the substance does to the body, the effects of the substance. So if it's a stimulant, as they are withdrawing, they're likely to experience some depressive symptoms, and for some, antidepressant might help, but the literature is not conclusive on specific medication for stimulant. Go on. What are the goals of detoxification? One, to provide a safe withdrawal from substances of dependence and to enable the person to become drug-free. Yes. And then to provide a withdrawal that is humane and to prepare the person for ongoing treatment. Oftentimes you find that in my practice, sometimes patients will come to me maybe a week or two and say, I want to come in as an inpatient. I'm dependent on so and so, I'm addicted to so and so substances, but I want to come in for treatment. I like to have a treatment facility. Please, I'm afraid of the withdrawal syndrome. How are you going to help me when I come in? Because I've experienced in the past, and I don't want to go through such anymore. Are you going to detoxify me medically? Do you have anything to help me to, to withdraw safely? So we sit down and discuss the various options, and they say, okay, give me 1 or 2 weeks before they come in. So it should be safe for them, and also provide with withdrawal that is humane. Sometimes some people say, look, just allow them to undergo the natural course of the withdrawal syndrome without actually intervening. For some, we say, like for the upper, you say, let them just go cold turkey. Don't even do anything. Let them experience the full withdrawal syndrome. Maybe that may deter them tomorrow from going back, taking the substance. But some people think that is punitive, and we don't have to do that. Let it be humane, and most times is medically assisted so that they can withdraw safely from the substance. For most opioids, we know that the gold standard is methadone. And then to prepare the person for ongoing treatment. When it's the first step, as we said, detoxification is just the first step. So when you do that, then you prepare the person for the next phase of treatment, because detoxification will not be able to solve the social, psychological, and other behavioral problems that come with addiction. So you have to do a lot of psychosocial intervention to be able to manage all the problems, psychosocial problems, and other behavioral problems. So detoxification will not do that, but it's just the first step, of the treatment process. Types of detox services. There are outpatient, home-based, or residential services without medication, but with psychosocial support, or social detox, we call it. But there are outpatient services with medication and periodic monitoring, that's medication supported. And then inpatient services with medication, medically managed. In my center, we do almost all of this except the home-based, detox, but we do almost all of this. And it has worked. It depends on the assessment and the severity of the substance use disorder. So we can decide and how motivated the client is, and whether there are other comorbid or co-occurring disorders or not. You can now decide whether you do just social detox with the cooperation of the client, or you can do one that is medication supported, and whether you do an inpatient or outpatient, detox. But at this juncture, I want to hear from the participants. What sort of detoxification services do you offer in your own practices? Please, can I hear from you? Kim will tell me. If you are raising your hand, Kim will allow you to share with us. Maybe 1 or 2 people, participants. I give you at least 2 minutes to do that.
I don't see any
Is
raised
anyone willing to
hands.
share? Okay.
Oh, here we go. Chisano Mafuto, go ahead and unmute yourself. Do you want, Chisano, go ahead and speak. Oops.
Yes, please go ahead.
Yeah, I've unmuted you. Go ahead.
Okay. The cases that we usually see in our facility is that most people have a severe form of withdrawal, and then we don't necessarily give them the medically supported withdrawal. Mostly it's medically managed in the inpatient setting. We have tried a number of cases to send them home, but to find that within the day they are not fully motivated. Within maybe 2 or 3 days, they are coming back with their history that they have still continued using the substance. So I think the best option in our case, it's the inpatient service.
Oh, thank you very much. Any other person, please?
Eugene raised his hand. There's lots of answers in the chat too, but Eugene also raised his hand.
Okay.
Okay. I think we do all forms of detox, which is usually in the mental health facility. But what currently I am advocating for is that we should be able to get a situation where detox will be part of the general medical services. So currently I work in a teaching hospital where I am insisting that when people come with alcohol withdrawal, they should be managed like any other medical emergency, because alcohol withdrawal is a form of delirium. So that if we get the general doctors to recognize withdrawal and its management, then they can refer after the detox to the specialized centers for rehabilitation. So I think we should be moving towards integration of detox into mainstream medical, general medical services, and get it a bit out of mental health per se, so that it is seen, we still are seen to propel the disease model of addiction. Thank you.
Okay, thank you very much for sharing. Okay, let's continue. As I said, actually, it depends on your setting and also the severity of the disorder, and also the level of motivation, and then the substance involved. Several things. So if you have a protocol, you'll be able to, allocate patients, those who need inpatient, those who need outpatient, home treatment, or those who need medication assisted, or those who can just do social detox. If you have a protocol, for mine is an addiction treatment as a center. So we offer almost all those services except the home based treatment. Thank you very much. Let's go on. Detoxification is only a first step toward recovery, but it's not treatment itself. As I said, it cannot treat all the social, psychological, and behavioral symptoms that have come along, or consequences of addiction. So you need to do other psychosocial intervention to be able to manage those. And then there's a small group exercise for us here, pre-treatment components. Can anyone remind us about what the pre-treatment components are? We discussed that yesterday. What are the pre-treatment components? Because I'm going to share you into different zones. It's supposed to be a group exercise, but because of the medium, we cannot do group exercise, but I'm going to share you into different zones so that you can take one or two and then tell us, what the key elements are. So please, can anyone share with us what the pre-treatment components are? Kim, any hands or Charles?
Yeah.
Yes. Is anyone willing to share? Okay. If no one's ready to share,
I'm sorry, there were answers. I kept trying to unmute, but I think now I'm unmuted. Outreach, assessment, screening, detoxification are the answers written.
Oh, great. Okay, great. We have outreach, we have screening and brief intervention, we have assessment and treatment planning, and then detoxification. So I'm going to share you and give you like 3 minutes to come up with the key elements, of the pre-treatment component you have been assigned. North Africa, I'm giving you outreach. You tell me what the key elements of outreach are, and then South Africa, I'm giving you screening and brief intervention. West Africa, assessment and treatment planning, and then East Africa, detox. What are the key elements of outreach, screening and brief intervention, assessment and treatment planning, and then detox. So I say again, North Africa outreach, South Africa screening and brief intervention, assessment and treatment planning for West Africa, and then East Africa detox. What are the key elements? This is supposed to be an exercise that you write it out, present, and also put it, on a print on a cardboard, and then post it on the wall for our own view, so that it forms like the continuum. We see all the components of continuum of treatment, and then you post it there. But we are not able to do it because of the medium which we are using now. So you will just read out the key elements of your own assigned components within 3 minutes. So we have just 2 minutes left now, because it's an exercise. This is an adult learning exercise, and then there are lots of repetition to help guide us to be able to assimilate and to remember, and understand what we are doing. That's why you find that even after doing this, you can go through your journal and then your manual, you'll be able to get all those. We have 1.5 minutes left. Just the key elements. And at the end, Kim will allow you, to read it out. If you raise your hand, Kim will allow you to read it out for the group.
Yeah, no
We
raised
have a
hands.
minute more.
No type. Oh, here's some typing. West Africa, administration of inventory to determine extent of the problem and level of intervention needed.
Okay.
Assessment must be holistic, needs assessment done. Recovery capital must be assessed and be available. Another answer to that question is must be individualized according to the needs of the client.
Oh, great. Thank you very much for being very active participants. Thank you. Yes,
there's more coming, but we'll go
West
on.
Africa, then any other region?
Let's see, we have East Africa, the process, which is, did you give them detox? There's a number of answers for that. The process of stopping substance use, clearing the substance from the body, and managing the withdrawal syndrome. Prevention of withdrawal symptoms and use of medication when necessary. Yep.
Well, thank you very much. So can we hear from either South Africa or North Africa?
Not yet.
You can consult your manual or your journal, because we've done that. We've done all the components.
Okay, we're getting an answer from North Africa.
Okay.
Outreach.
Yeah.
It's coming. I can see her working on it.
Okay, great. Let's give her maybe a minute to
take care of shame, stigma.
Okay.
In denial. I think we should go on, even though typing's going. I think we should move on.
Okay, yes, because we are constrained by time. So, but it's good you carry out the assignment, because it helps us to revise what we have done, and also it helps us in understanding what the module is all about. So we are moving on to another aspect of treatment, which is case management. It's part of treatment, but sometimes it's an integral part of treatment, but sometimes it can also stand on its own. So what is case management? It's an integral part of treatment, and it starts from the screening and assessment to ongoing and recovery. For instance, you screen and assess, and then you find that the client has severe risk. Then you assess, and after you assess, you are able to make diagnosis. You might even admit into treatment, detoxify, and then kind of all the primary treatment. After that, you discharge the patient, to an outpatient, and then you continue from there. So all these are, fall into case management. So all the services that are provided for an individual, from the screening to ongoing and recovery, are all, fall into case management. And case management, or what is it? The coordination of professional, social, and medical services to assist people with complex needs, often for long-term care and protection. We know that when an individual is addicted, we know that addiction involves many, dimensions of one's life. There are biological ones. You have the social, you have the occupational, you have family, spiritual, and so on and so forth. So you want to manage all those, and then various professionals may be involved in one aspect or the other. And when you start with the clinical assessment detoxification, how do you ensure that all these things are carried out and all the hurdles or all the gaps in the treatment are plugged, and the individual, is happy with the treatment, or able to maximize and make the treatment, efficient, so that the client can move from one, service to the other without just seamlessly. That's what the case manager does, or case management is able to harness all, of the services and then coordinate them for the client to make it easy, so that the client, can carry on with the treatment. Before we started the UTC training in our center, we didn't have a case manager as such. Everyone was doing one aspect of case management or not, or the other. But after the UTC treatment, we say, okay, let's standardize our practices. We decided to assign a case manager and then one or two other staff that are in the case management. So it makes the work, easier for you, because you're able to coordinate the services for the client, and then the treatment plan is followed as you plan it, and nothing is left, and the clients are happier for it, and we see that the results, we get better results, than we previously, had. So case management is actually a very interesting thing. And then case management, what is the purpose of case management? Monitor transitions of clients between levels of care to assure there are no gaps in service, yes. And then coordinate the range of services needed by clients, and serve as a single point of contact for each client to find and mobilize needed resources. From the screening, assessment, and everything, the detox, and then you have the counseling sessions, you have the life skills, and so many other things, going on for the client. Then you talk about housing, you talk about school, and so on and so education. Then who actually ensures that everything is actually carried out as planned? If the case manager is better able to coordinate all these services for the client, and then you have one person that the client can, that can help the client solve the problem. And for us, even after their discharge and their continuing care, when they have problems, they can call their case manager, and then the case manager can relay the problems to the professional involved, and then we monitor them even when they are at home, before they actually come back for checkup or whatever, or even when they're in crisis, they can notify the case manager, and then they link up with the other professionals. So we do that in our own environment. I don't know what is obtainable in your own practice. Can anyone tell us what you do, whether you have case management in your own practices or not? Do you have one person assigned as a case manager, or everybody does some form of case management? I want to get responses from the participants. So please, Tim, help me. Does anyone want to share with us what is obtainable in a setting?
I think people are typing in chat. But...
Okay, please, you can help me read one. Then we'll move on.
Oh, wait, you have a raised hand.
Okay, please.
And I can't pronounce his name. Higator? I'm sure I'm saying that wrong. Higator? Higator?
Yeah, Higiato.
Higator?
Yeah,
Go ahead.
Higiato.
Sorry.
Yeah, the name is Higiato Adanyofo
Okay.
from University of Benin, Benin City, Nigeria. Yeah, in my center, we don't have a case manager.
Okay.
You know, at the head of the team managing the patient is the consultant psychiatrist. So invariably, it serves like the case manager. So it delegates resident doctors, sometimes social workers, at other times the clinical psychologists to coordinate the related services as the case
Okay.
would determine. I think we recognize the place of a case manager, but I think owing to paucity of manpower,
Yeah.
it's been difficult to assign, or maybe because of deficit in training, it's been difficult to assign case manager to different patients. Otherwise, we recognize that is the ideal, and by the grace of God, we are moving towards that. Thank you.
Thank you very much for sharing your experience from Benin. We used to do that, but after the training, I said we had to sit down and then reorganize our services, and then we had an office of a case manager, and that has actually helped us to improve on our services. Let's move on. Case management. It has to do with services tend to be scattered or difficult to access. Usually, sometimes there's no service that provides everything for a client. So you have to liaise with other services. And for some, in fact, they may just offer just one component of the treatment. So you also have to get, collaborate and liaise with other programs to offer other components of the treatment. So a case manager will facilitate that and will coordinate all the activities. So it helps to fix all the pieces of the puzzle together. The service are scattered, and sometimes, especially in in my city, the patient can easily get discouraged. But when you have a case manager who works with the client and then facilitates, the consultation with different programs, they find it very interesting and they become more motivated. For instance, some of our clients that are HIV positive, and then they need to go, to access services for those who are HIV positive. The case manager accompanies them, sometimes first timers, to the clinic, HIV clinics. And when the case manager goes with them, they are willing, and then it helps them, to be able to adhere to whatever treatment is given, and they feel happy about it, that somebody is there to support them all the way, through. And then case management manager help put the pieces together for clients. Yes, sometimes they get confused with the kind of services, and then they get discouraged too. They may not even have the resources to, navigate from one service to the other or program to the other. What are the functions of case management? Yes, in fact, it starts with assessment, service planning, linkage and referral, monitoring, advocacy. All these, are functions of case management. Assessment and service planning. Assessment and service planning are closely related to the initial assessment and treatment plan discussed earlier. Yes, when you assess and then you come up with a diagnosis, you have to plan, the treatment with the client, and then the case management work starts right from there. And then a case management plan can be incorporated into a client's overall treatment plan or can be done as a separate process. For instance, where you need a service for the client that is not offered at all by the facility, then you can now, the case manager can go, out of his way and to look for that service outside that program to enable the client to access, such services. But it can also be part of the treatment plan and the monitor and ensure that everything that is planned for the treatment is actually carried out. And then the patient doesn't fall, through the cracks in the system. Linkage and referral. Linkage and referral are critical because no one program can meet all of a client's needs. None. That's very true. And then inter-program case management connects programs to one another to provide more services to clients. Yes, you can collect one service or that, but you can have, for instance, in my facility, we have most of the things that the client needs. So the case manager only goes, navigates between the doctor, the psychologist, social worker, physical health therapist, if it is a spiritual a counselor, then ensure that the client gets all those. And if it's occupational therapy, sometimes even the education. For instance, some of our clients who have gone to 1, 2, 3 conventional universities and have not been able to graduate, we encourage them, motivate them. They say, okay, I want to study online. Then we provide a facility for them in the treatment center where they enroll in an open university, and then they start their online courses there, and they have been doing very well. So a case manager helps to actually coordinate all this for the client. Linkage and referral. Through linkages and referrals, counselors can help clients obtain treatment for mental disorders, family therapy, childcare, transportation. Yes, counselors can do that, but a case manager will be able to do it better, and the counselor, focuses on counseling, and then the physician may focus on maybe detox and then maintenance therapy and other things. Then the family therapy will come, and do his own, and then the childcare, and then the transportation facility. So the case manager is able to fix all those and link all those pieces of the puzzle together. Linkage and referral continued. Housing assistance, financial assistance, legal assistance, HIV/AIDS or other medical testing and care, educational or vocational service. All these are things that a client needs. Of course, when he leaves, he has to, sort out the issue of housing, finances, and he may be involved in some criminal justice problem, and then he needs legal assistance, and they may also be HIV positive, and they need treatment for those. And then what about the educational or vocational services? You need to be able to liaise with services programs that provide all this for the client. But you as a therapist might not be able to do all this. But when you have a case manager, is able to coordinate, or she is able to coordinate those things, and it makes the work easier. Monitoring functions. A case manager, yes, ensures that the client engages in services and monitors the client's progress, identifies barriers and works with the client. Yes, and referral sources to overcome them, and coordinates communication with the multidisciplinary team. That is the function of a case manager. And advocacy, speaking out on issues of concern to apply influence on behalf of a person or persons. So the work actually involves advocacy, where case managers interact with many systems to advocate for their clients, including other organizations, healthcare providers, the legal system, and families. Sometimes patients have problems with all this, but you as a therapist have a lot of patients before you to attend to. You don't have the time to go to the organizations and meet them, or to go to healthcare providers, maybe insurance providers, or you go even to get legal support, or even the families. But the case manager can coordinate all those. So advocacy tasks. Case managers can educate non-treatment service provider about a client or substance use problem in general. Yes, sometimes they are ignorant about what this problem of addiction is all about, and all the various dimensions that were said earlier on. But the case manager can help educate them on such problems. And at times, the case manager must negotiate with a program on behalf of a client. Sometimes, because of discrimination, social exclusion, prejudice, whatever, some people don't really want to have anything to do with our own kind of clients. But the case manager can really help to negotiate, for a program, and then they are accepted, and then they're able to access the program, and it helps them as part of their treatment plan. So large group exercise, we don't have the time because I'm getting into encroaching into BTC's time, but there's supposed to be an assignment for us here. It's a group assignment which I wanted to give it to the different zones as regions, as I did earlier. It has to do with case management. It's divide into groups. First of all, case management definition. One group is supposed to define for us what case management is all about, and then the other one is supposed to give us, the purpose of case management, and then the third group is supposed to tell us about the functions of case management, and then the fourth one is supposed to tell about the case management challenges. For instance, when you go for advocacy, what are the difficulties you have? For us, we do a lot of advocacy for our own clients, and there are so many hurdles that you have to cross on behalf of the client, because they will not listen to them. They are stigmatized, and nobody really wants to engage them. Even the society is sometimes afraid of them. But you, as as a case manager or a professional, can actually advocate for them. And with proper education and sensitization, people get to know that, oh, these people, after all, are humans, and they can be useful to society. And if we just play our role and accept them. So different treatment centers or facilities have their own peculiar challenges, but we don't have the time. But this you can do at home, and then maybe you can report it in the email. North Africa, I will give you this. What you help us define case management, and maybe post it on the mail. And then South Africa, tell us about the case purpose of case management. West Africa, tell us about the functions of case management. And then the fourth group, that's East Africa, tell us about the challenges of case management. You can post them on the chat or even the email. Thank you very much. I think we allow Beatrice now to continue.
Thank you, Moses. Thank you, Morekwe. Thank you, Kim, for taking us through the elements of pre-treatment. I hope that today my speaker can be heard, because sometimes it does become problematic. So we have looked at the different, remember we've been looking at the elements of the continuum of care. Remember, we have said continuum of care has to do with the whole range of services that our client needs to meet their needs holistically, because we said that recovery is holistic, and therefore continuum of care is about the whole range of services our client needs. So Morekwe and Moses have taken us through the pre-treatment phase, where they talked about outreach, screening, assessment, treatment planning, detox, and case management. We are now moving to the second phase of the continuum of care, which is primary treatment. And in primary treatment, we're going to be talking about several activities that happen, and one of them is counseling, which is very important. Of course, there will be testing or drug testing. We're going to be talking about pharmacotherapy and other different activities that happen in the treatment phase. And then, of course, in the final phase of the continuum of care, we're going to be talking about ongoing or continuing care. So now, talking about primary treatment, I'm going to focus on counseling. I'm going to be talking about individual and group counseling. I'm also going to be talking about the types of groups, and also something regarding what we can do in terms of some of the activities we can cover in group counseling or group psychoeducation. And I will say something a bit about drug testing as part of primary treatment. Now, what is counseling? I know some of us, I mean, that's the interesting thing about this curriculum. When we were doing physiology, it was like a walkover for the people in health science. Now, when we come to this section of counseling, it's probably going to sound very basic to those of us who are in the field of counseling. So we beg that we give, we tolerate and accommodate each other because of our diversity. And so when it is very basic for you, please understand it is not as basic for everyone else. So counseling is basically an interaction between a counselor and a client or a group of clients. It's important for us to understand that the aim of counseling is to help the clients with problems that are related to three things: affecting their thinking, affecting their emotional well-being, and also affecting their behavior. We should note that clients can be counseled at individual as well as at group level. In many of our treatment settings for SUD, we focus on individual and group counseling. Our key goals include to reduce and stop using of substances. That's the key goal, because remember, our clients are coming to see us with problems of substance use. The second one is building skills to sustain their recovery. That's important, and we're going to be mentioning some of the skills we can build. The third one is to adhere to medication. This is important because we've been saying that sometimes we use medically assisted therapy. Sometimes we use medication, just like Moses said, for detox. And we want to ensure that our clients are adhering to the medication if they're using it or if we have prescribed, and also to the recovery plan. We also want to address other non-drug directly related issues, which could be personal, family, and social, and which indirectly contribute to the substance use problem or are important for recovery. Now, when we talk about individual counseling, what is it that we focus on? Now, individual counseling sessions will vary. They will vary depending on the type of program, the stage of the client's recovery, as well as the unique needs of the client. I have seen that in my country, maybe because of resource constraints, a lot of people prefer to see clients in groups. However, we have clients that seem not to do well in groups because of their unique needs or the stages of recovery. And that's why we need every time to think about one of the principles of treatment, that treatment must be visualized. So that, like Moreko said, one size doesn't fit all. So let's focus on thinking about what are our unique clients' needs, what stage of recovery are they in. If they're in very early stages of recovery, they may not even do well in your groups because they are still not, they haven't accepted they have a problem. Maybe they are still in pre-contemplation. And so the place of individual counseling is very critical in our programs. Now, when you do individual counseling, what is it that you focus on in a counseling session? One of the things you could do is find out how the client is feeling. I mean, many times we want to ask the hard stuff and the big things, but sometimes all we want to be asked is how we're feeling. I do know that many of us in our own personal lives like it when people apply counseling skills in everyday talk. If someone meets you and just asks you how you're feeling, it's a nice thing. They are concerned about it. It's the same thing with our clients. It's part of the engagement Moreko was talking about. The second thing you could talk about with the client is what are their reactions to their recent activities that they have been undertaking. Maybe they've been attending a group meeting. Maybe they've been trying to do some of the activities of your program. It's nice to find out from them their reactions about them. Sometimes it's even about the medication that they are taking. It's good to find out how they feel about it. You might just discover they're actually not taking your medication because they have certain ideologies about it. Like one client stopped taking medication, and when we inquired what it was about, we realized they had gone to the Google and read the side effects of the medication, and they said they were not ready for those side effects, so they stopped taking the medication. We wouldn't have known if we didn't ask, how is it going with the medication? That's a small question that looks very basic, but that can unearth a lot of things for you with your clients. The other thing is that just exploring how the client is spending their time outside the sessions, particularly for those of us who are seeing our clients in outpatient, is an important question. Again, it might open up very important things that are happening in the client's life that could be obstacles to recovery. The other thing you can do is to inquire about drug use. This is important just to know whether the client is continuing to abstain or whether they are having issues of cravings, or have space to speak about these issues. It's also good to ask them whether they have target issues. This is important again, because you're focusing on the substance use treatment, but the client may have encountered a difficult event back home in their workplace, and that might be becoming an obstacle to recovery. So asking about it could be important. So find out, do you have something urgent that we could talk about before we go back to what we were talking about? You can also review their treatment plans and the coping strategies. This is important because making a treatment plan is one thing, but following through that treatment plan is another. So when the client comes in, find out how are they doing on the various aspects of the treatment plan, what strategies are they using, what obstacles are they facing, and then begin exploring what strategies they could use to improve. And then finally, very important, and I like this bullet all the time, even in day-to-day life, just address fears and anxieties related to change. You know, the biggest challenge we are all facing with COVID-19, I think in many of our countries, is the whole idea of fear and anxiety. Even in recovery, when clients are trying to change, remember the pre-contemplation. Remember the contemplation when they have ambivalence. As you ask about fears and anxieties, you might just catch that the client is about to go back to pre-contemplation. And so you can begin to build their motivation again in order to push them towards change. Now, again, other things you can do as a counselor during the session is to provide personalized feedback on substance testing results. So supposing your client got a test, a drug test when they last came, you might want to give them feedback, or even that very day, you might want to give them feedback as part of the counseling session. And then of course you can probe sensitive issues that a client may not talk about in a group. That's very important because while our clients are all using substances, they all have unique needs. So probing any sensitive issues will help. The other thing you can do is to help the client access services. Sometimes they may not know where to get some of the services Moses has just talked about. So by asking about those services, by giving them information about that or the services and where to access them, will be you acting as a case manager. And by the way, I want to mention that in this curriculum, we are not emphasizing too much that you create positions of case managers because we know it may not be sustainable, but we are saying we need to ensure our centers are performing the functions of case management. So it might be the counselor, it might be the psychiatrist, it might be the director, but someone has to coordinate the services the client requires. So part of your responsibility here could be to help the client access services. And of course, what else you can do in the session is to give the client assignment. And of course, remember when you give assignment to review the next time that the client comes. Now, how do you end a session? An interesting question that many people ask. You can actually end a session by summarizing what you worked on in the session. You can also summarize the client's plans and also do a schedule for the next few days. It's nice as you do this to involve the client in all this that you're scheduling so that it doesn't look like your business, but it is a collaborative process. And of course, the other thing you need to do as you end the session is to schedule your next session with the client and agree on the time that works for them, not just for you. Now, the other type of counseling that we can engage in is group counseling. It's a key primary activity or primary treatment activity. It has many benefits beyond what individual counseling has. Remember, in individual counseling, the therapeutic gain comes from the counselor only. But in a group counseling, the therapeutic gain comes not only from the counselor, but also from the fellow group members. That's why it has got a whole, range of benefits for your client. For example, in the first bullet, it provides an opportunity for the client to develop communication and socialization skills. As they interact with the group members, some of them will learn how to take turns in conversation. Some of them will learn how to listen. Some of them will learn how to express themselves. These are skills they may have missed out on wherever they were in their substance using life. The second thing is that it creates an environment in which clients help, support, and confront each other. This is important. Not just helping and supporting, but also confronting. Sometimes, of course, we talk about gentle confrontation. And we are not confronting by being aggressive on the client. We are confronting by, helping them discover that there is a discrepancy in what they are telling us. For example, if they tell us that I really want to get back my relationship with my wife, and then they tell you that I don't think I'm going to stop using this substance. And in the last session, they said that stopping the substance was causing them difficulties with their wife. And now they are telling you that they don't think they can stop using. There's a discrepancy right there that fellow group members may point to the client, and that helps to confront them to start thinking a little more about change. Now, a group also introduces structure and discipline, which is normally absent in many of these clients' life. Remember, their lives have been chaotic, while doing drugs. So while they come into a group, remember they must keep time. They are the group norms. Members follow up on each other. People get feedback. People get challenged. All this introduces structure and discipline and helps them to learn how to work within certain norms within their environment here and outside of the group. The other important thing is that the client is able to broaden their understanding of recovery capital and barriers to recovery capital. Part of the recovery capital comes from right there in that group. Sometimes they may actually discover some of the barriers to recovery from the feedback they get in that group. It also helps to support individuals' assessment of critical risk and protective factors. Sometimes your client may not have understood that a family member is a protective factor or a risk factor. But as the members point that out as the client tells their stories, that becomes useful knowledge for your client. It also advances individual recovery because within the group, each individual has their own goals that they are pursuing, and they are actually supported by the group. And finally, we are saying within a group, the leader can transmit new information. Many of these groups become psychoeducational groups, and we're going to be talking about that. And so you can take advantage to build the client's knowledge and skills around some of the new behaviors you want them to adopt. Now, when we talk about the size of the group, sometimes I know I have been to centers where you throw in your 30 members into a group. It is recommended that an ideal size is between 8 and 15 members. Why? If it gets too large, it becomes a crowd. Some people get lost in it. People cannot even participate effectively. If it's too small, it lacks variety, so that you find that the richness and the support that comes from the diversity is missing. So ideally, 8 to 15 members. Of course, some could be slightly smaller, some could be a little bigger, but this is the ideal. When it comes again to meeting time, it's ideal to meet for 1.5 hours. Sometimes I know in Africa, because we have a way of beginning our own issues, you know, like even the ceremonies of how we greet each other, how we settle down are a little more elaborate. So sometimes our groups can run for much longer time. But sometimes the danger of going too long in terms of timing is that you lose the concentration and attention of members. Now, some caution about group counseling. And I want to say this based on this slide. Group counseling could be one of the most abused activities in treatment, primary treatment, because when a center doesn't have enough resource, they decide we are going to be doing groups. When they don't have enough counselors, they say we're going to be doing groups. And sometimes these groups are just doing very little because they are not even structured, they are not well managed, they have been there, some are dozing in the group, others are doing their own stuff in the group. So these are some of the cautions that we are being given here. That we should assign people the same, for example, who are of certain characteristics. If you have perpetrators and victims of domestic violence, it's good to put them in separate groups for obvious reasons. The victims could easily be feeling traumatized by the presence of the perpetrators, and there can be a lot of animosity in that group. If you put neighbors, friends, relatives, and spouses or significant others into the same group, you might discover that their focus is not in the material you're working on, but on their social relationships. This is what we call dual relationships, people with more than one relationship. So if possible, you could avoid. I do remember a treatment center that put in 2 relatives, 2 cousins in treatment at the same time. And whenever they were in the group, they'd be making fun of the group activities and comparing them with activities back in their homes. And they just ridiculed the whole program. They actually had to be thrown out, the 2 of them. So these are some of the things we are cautioned about. Of course, the other thing is putting certain clients with certain characteristics in groups. People who are extremely introverted or socially anxious do not do well in groups because they give them a lot of anxiety. The pressure that gets to open up becomes intimidating and can actually be traumatizing for some of these clients. So it's good to reflect on that. Sometimes we have clients with severe mental disorders who are even psychotic. Others are extremely neurotic. Others have got, severe stress and become emotionally happening. We have to think about this before we put them in a group. And of course, the other thing is clients who violate group principles or who can't control their impulses. This may not do well for your group. It might actually demoralize the entire group, and then the group doesn't achieve much. So when you think about these clients, consider putting them in individual counseling as opposed to group counseling. Now, in this slide is an activity. This activity is based on 2 resource pages. We have resource page 6.3 and 6.4. They give you ideas of some of the activities you can actually do with groups. They will give you ideas of the different types of groups that you can form, the different psychoeducational group materials you can work on and topics so that they become fruitful to your clients. So I'm going to stop sharing this slide and go to another document, which is basically the trainer manual, and we can be able to see, this activity. So when you have time, when you go back, please remember this very nice activity that can be done. So you ask your groups to read resource page 6.3 and 6.4. They can make a presentation to the rest of the class. So this is just an overview of what psychoeducation groups do. They are basically meant to help clients acquire certain skills. Now, it's important to note they are low key emotionally. They are not intense in terms of clients sharing their emotional states and their experiences. They are more like training groups. They are more like you're equipping them with information, you're equipping them with knowledge, you're equipping them with skills. So mainly the approach is didactic, but you can submit videos aside because learners have different styles. So it's more a learning group. That's what a psychoeducational group is about. And you can focus on educating clients on many things. You can educate them on the substance use disorder. You can also educate them on other conditions like the mental disorders, which are commonly associated with SUD. All this is important. And these groups can address both clients as well as their families. You may choose to have families separate from clients. You can also choose to have them combined depending on the topics that you're covering. That's the important thing. They are good at the beginning of treatment because they help clients understand for example, addiction as a disease. They begin to understand how it manifests itself. They begin to understand how it affects the different areas of their life. And so you see here, you have all the topics that you can address in psychoeducational groups. And now it's here. So if you have a shortage of topics, this specific resource page will give you all the ideas, including looking at some of the risks. The other day, I was talking to one of my students who's on internship, and some of the problems the clients were facing were to do with adherence to medication. You can actually do a psychoeducation group and cover the topic of adherence to medication and the challenges and how to overcome them. You can see HIV, AIDS, and hepatitis C. So you can look at all the challenges you have in your center and see how you can address them through a psychoeducational approach. Now, so they can do them at different stages. Like you can see in the early stages of recovery, there are the topics to cover. At the stage of when they're coming towards the end of the program, relapse prevention. In terms of continuing care, when they're ending their program, there are also many topics that you can cover. That's what resource page 6.5 is. Now 6.4 is another resource page which focuses on types of treatment groups. And you can see again, it emphasizes that these groups focus on understanding motivation of the client, especially the treatment engagement groups. You can also have relapse prevention groups. You can also have skills development groups. So what we are saying, if you want to make group work useful, understand what is your goal. Is your goal to equip the client with a certain skill? What skill is that? What stage of recovery are your clients? Sometimes I find it difficult when people put clients who are in early recovery with those in middle recovery with those who are thinking about discharge. The ones who are about to be discharged are anxious about, transitioning back into the world. The ones who are in early recovery have just entered and are adjusting and trying to understand this model. So if all of them together in one group, that's much. So let's reflect about what are the needs of our clients, who can fit in what group together with who, what skills do we want to train them, what goals do we want to achieve. Then that way our groups are going to be more meaningful. So that's basically what that's about. And finally, of course, we have support groups which identify people who have certain issues. They are a little more intense than the psychoeducation. We also have special interest groups. For example, within your center, you have some clients who have unique personal issues. You might have clients with HIV/AIDS, so they have, in addition to the SUD, issues of HIV. You might find clients with co-occurring disorders in addition to SUD. May form another special interest for those types. And so it's a wonderful, approach. It's a wonderful technique, but can be misused. But if we are careful to think about what we want to achieve, if we are careful to think about the unique needs of our clients, we are going to be able to maximize on group work. And so I had to take more time to look at these topics out of this session, and let's share more on our discussion group about what are some of the types of groups that you are using in your treatment center and the challenges you're facing, and share with us some of the insights that you have gained and the lessons learned from this resource page 6.3 and 6.4. So thank you very much.
Thank you, Beatrice. So we finished with a minute to go. Thank you all. We're not meeting tomorrow. So you'll all have a day off, but we are meeting Monday. I don't think I'll be here Monday. I think Carrie will be here Monday. And then Tuesday, Jessica and I will be back again. I will get out the assignments, an email with the assignments to you, although I didn't write fast enough, so I might have to get those from the instructors. Same time, Monday evening. So we'll see you then. Bye, everybody.